So we welcome Dr. Ashish Nagpal, who's a medical director and consultant cornea surgeon at Dr. Nagpal Center for Cornea and Subspecialty Eye Clinic at Ahmedabad. The patient that he is going to operate is a 66-year male who complains of mass in the right eye since 5 years and has been diagnosed with right eye pterygium. Patient is planned for right eye pterygium excision with scleral fixation glue with conjunctival autograft. And also there's a significant amount of astigmatism that we can note here of minus 3.5 cylinder in the right eye for the patient. So please, I request Dr. Ashish Nagpal to please take over the surgery here, please.
Great. So first of all, welcome Dr. Ashish and thank you for making in time. You have just landed, we know that, and we are looking forward to learn from you. Thank you.
Thank you, Dr. Vardaman. Can you hear me?
Yes, very clearly.
Thank you to AIOS. I think we will proceed with our case. This is a pterygium that we have here, and this seems to be some sort of a scarring underneath the pterygium. If you can see, there's some bleed over here. This is just because I was exploring. I was trying to. The first thing that we do is we expose, have a nice look preoperatively at the conjunctiva to look for the donor. And what we are planning in this case is to do a pterygium excision and then do a conjunctival autograft, superior or supratemporally, with fibrin glue. So we'll just touch upon some basic aspects of how I go about doing the pterygium. So I think first thing is to demarcate, to, as we have all learned, try to figure out where is the head of the pterygium, where is the neck. So this is the head of the pterygium. You can see some scarring here. And so it doesn't seem like a progressive pterygium to me. There's some sense of a Stocker's line, which is a pigment deposition, which occurs because of the tear film, as we all know. So what I normally do is we will avulse the pterygium. So that's the technique that I will demonstrate.
Sure.
So in this case, I'm just taking this Kelman and trying to pass it through. Even in a true pterygium, sometimes you can make way and pass it through. Although that is the differential thing that we usually clinically take. But here it's passing through the tenon and coming out. Scissor. दूसरी वाली दे दीजिए. So what I'll do is, so this is the whiteness over here that you see is probably the elastotic degeneration that you can see here. So what normally I do is I keep the limbus as the landmark, and in this case we will cut along the limbus. We have already made sure that we are not touching anything else behind. Can I have a swab? Just a swab. And you can see there is some pre-existing hemorrhage, there is some bleed happening. So this is probably the bulk of the pterygium. There is still some pterygium over here, which we will deal with later. So like in any surgery, we are looking at what is the final, what are we aiming for. So in this case, it's more of a cosmetic disfigurement that we are aiming for.
How much of astigmatism does this patient have, Dr. Ashish? If anybody knows, Dr.
Can you ask
Mansi
Dr. I think can Dr. Amrita chip in?
Yeah.
Because I don't have the details right now. Can you put some saline on the cornea? या आपके पास एक वो वेक्सेल है, एक वेक्सेल है आपके पास? नहीं, सलाइन दे दीजिए. ये सलाइन है? नहीं, आपके पास एक वेक्सेल है? कौन? हाँ. So I think few things to remember. I think we are always, I think with the passing of time, I think all surgeries have become very fast.
Correct.
And pterygium seems like a very innocuous thing. But as cornea surgeons, we feel it should. So the astigmatism is minus 3.5 diopters, I'm told.
That's quite significant, right? And we can also see, I think there is a cataract sitting in, it looks as if.
Yeah, there is a
Yes, yeah.
cataract. There as well.
So
So that
only
is another thing which can be discussed. It's always
yes,
whether to remove before
yes.
and
And
after.
what is the so for our delegates, can you please tell what is the ideal timeline that you look at between the cataract surgery and pterygium surgery?
So for me, I would look at least 8 weeks. 3 months is even better
Okay.
because there is some remodeling which occurs. So what I'm demonstrating here, Vardhaman,
Yeah.
I think everybody think there are a million ways to excise a pterygium.
Right.
I think, can I have a swap? So here what I'm trying to do is I have cut the body of the pterygium and I have demarcated this. So I like to follow this plane. So there is already a cleavage plane here.
Right.
So instead of, one can approach from here as well, but you can see there is a scarring.
Yeah.
So here I would prefer to go from here. Thank you. इसको थोड़ा सा इसको कट करके दे दीजिएगा. So here ideally you should take two sort of tooth forceps. Sometimes you need a little traction. And the forces are similar to as what you would do for a rhexis, I think. So my idea is to try and see if we can just pull on it
Yeah.
and let it follow the plane as you can see here. So it is kind of
Nice.
peeling off.
Very nice.
So it's more what we call as a pterygiorhexis
Yeah.
because we like
Yes.
whatever. And here there is a tag here you can see, but we'll deal with that later. First we can just remove this part.
Very nice.
So we get this clear plane. Here we can
Yeah.
just also pull again separately.
Right.
So you can see we have the body, the neck and the head of the pterygium here.
Perfect. Very nice. Very nice.
So, so this is one way sometimes, and you can see there is a deeper scarring over here.
Yes.
There's almost a scar extending. So this could also be a mix of a, can I keep this? Histopathically.
So all your pterygiums after excision, you send it for histopathology analysis, Dr. Ashish?
Yes.
Yes.
So we, anything that we remove from the eye, we send it for a histopathology. Pterygium more so because it is established that 1 to 5% may have some dysplasia.
1 to 5%. Right.
So sometimes, so I think it's a good practice to do.
Yes. I think that is a good
and
learning
these
for
times-
all our delegates because I think most people may not be doing that. So I think that is something they have to take as a pearl and start doing in their practice.
So now that we have removed the pterygium, another important saline darling. So now you can put some saline and then you can just try and see here, because the pterygium is not involving the pupillary area, what we are concerned about is now a little bit of functional smoothening.
Yes.
So here what I'm doing right now is just trying to use the 15 number blade
Right.
to just see how much of the loose epithelium comes off easily,
Right.
because the bed looks fairly smooth here to me. So I'm just removing some of the
So using
epithelium
this
and the
15
scar
number
area. as you can
blade
see there is-
versus using a diamond burr, what is your choice
Correct.
and how do you go?
So that's what we have kept the burr also standby.
Okay.
But what I would say is it's not, if there is
Required.
any irregularity, if there is any bumpiness,
Right.
especially at the limbus, so that's the reason why we want to smoothen it up.
Perfect.
So it can be a case decision.
Right.
Here you can see the cleavage plane as I'm not cutting.
Right.
I'm just separating it.
Perfect.
So here there is no cutting dissection. So the idea is just to smoothen the limbus. I don't want any ragged edges at the limbus where we will be putting the graft because it enhances the cosmesis.
Right.
And in such cases, as we see preoperatively, it's important to talk to the patient so that they do not have any misconception, because in this case there is a scarring.
Right.
So obviously this we cannot deal with at the time of pterygium surgery. So
Yes.
we should also counsel the patients that there may be still some scarring.
Right.
We are removing the outer skin which is abnormal.
Right.
So I think this seems fairly okay. I don't think we will need to use the burr over here.
Right.
but it's a personal choice, I think.
Yeah.
So some people may prefer doing a burr, but sometimes in my hands I've seen the burr, we tend to over sort of, go through the Bowmans and cut through it.
Yes.
Sometimes I tend to.
Yeah, one has to be
really-
very careful in using the burr. It can,
And
I
sometimes
mean, it is
with
easy
the
to
thinning.
overdo with the burr.
Yeah. The second thing is cautery, whether we need any more cautery or not. So the idea is to be so I think the key word here for any pterygium surgery, I think everybody, all of you are good, excellent surgeons, you're doing cataract, so I think pterygium surgery does not require a different skill set, but I think one needs to be gentle and one needs to give it time. That is all that I think that we need to give. Here you can see the primary pterygium, so there is not much of a conjunctival or tenons, growth here. Can I have this? So at
Is
this point, what I'll do is, I'm just trying to see if here at this point, if it's a fleshy pterygium, you will have a lot of fleshy
Okay.
tenons underlying it. Is it centered for you?
It is centered. Is the next case ready? Otherwise, you could do the bed and we would come back to you again, Ashish.
Yeah, sure, as you say, ma'am.
So, Gaurav, is the next case ready? And then we can come back to Ashish again.
So while we are here, I'll just demonstrate this. Can I have it? It's important to separate the tenons and the conjunctiva.
I'll give a call to Dr.
Am I audible? Vardhan?
Yes,
Namrata,
yes,
audible?
yes, yes.